Unstable. Unstable angina.
Stable.
Stable.
Variant.
Kind of. Non-STEMI and STEMI. Which non-STEMI and STEMI are what? An MI. They do put stable angina underneath there, kind of. What actually is angina? Chest pain. Why do we consider it stable?
Is there something that causes it?
They are hemodynamically stable. When do they usually say they get this?
Exercise.
After exercise? What if you had a panic attack and your heart rate goes up to 180? Is that going to trigger it? Maybe. Guys, there are different diseases that cause coronary artery spasms. Those aren't STEMIs. Those aren't that. That doesn't mean it doesn't hurt just as bad. And then sometimes they're having ischemia. Don't hurt at all. I'm not downplaying this because what do you think the stable might lead to? The unstable, right? Risk factors. Everybody in here can check off 99% of these boxes. You can't get rid of stress a lot of times. You can try to help negate some of the things. Stimulants. Y'all stopped at methamphetamines. I ain't giving up my coffee. I don't care. I'll have a heart attack. Why is smoking a risk factor? What does it do? It makes your arteries hard, so they can't constrict like they normally do. Obesity, BMI over 25. Why diabetes? It pretty much does the same thing, right? And a lot of times, if it's type 2 diabetes, what else do we have up there? You got hypertension. Diabetes type 1 is because you have none. Diabetes type 2 is because of you. Which means what? Sedentary lifestyle. Bad diet. Girl, we live in the South. If you can fry it, put lard on it, we are going to. Fried Twinkies, fried Oreos, fried everything. If it sits still long enough, we will fry it. So you've got this triad. You've got obesity. You've got diabetes, which affects your vasculature and your kidneys. And it leads you to high blood pressure because it's affecting your kidneys, which what does that have to do with high blood pressure? The RAS system. And guys, that is confusing. I'll be honest, I probably could not walk you through the whole thing. But that's why. Why is hypertension a risk factor?
It says it causes inflammation of the vessels and that it attracts the LDL and it dies.
It does. Blood pressure. What'd you say? Somebody said it. The pressure is up. What do I care about that pressure in the system? What is your heart? A pump. What is the pressure? What it has to beat against, right? Systemic vascular resistance is your systemic blood pressure. If your blood pressure is 300 over 150, that's the highest one I've ever seen. She had a stroke 2 minutes after I walked in the door. How much work does that put on the heart?
A lot.
How long can your heart do that?
Not very long.
If it's just gradually going up, your body kind of gets used to it. It can't deal with that. Your heart is going to what? Fail. In the beginning, is pumping against all this pressure. So what happens when you work out? What happens? You get the muscles, right? Your heart can only work out so much. The muscle starts to do what? Stretch, hypertrophy, heart failure. There's too much pressure that the body is pushing against. And you smoke, so your vessels are not flexible. What does that do to cardiac output? It goes in the toilet. We're going to talk about all that during shock, but you will be able to know that walking in the door looking at your patient. Diet, high cholesterol. This is a genetic thing, and I think this is old. Used to, we would say the person with the highest risk, African American male above 50. I said this last time in one of the girls, and I did not look it up. I'm going to have to look it up. This used to, but I think women's rights. I think they're even now. This is a genetic makeup. Like my next door neighbor is the picture. Everybody in here that looks healthy, that's her. And girl, her blood pressure's through the roof. It's just genetic. It just sucks that you got that and you're doing everything right. Why does this happen? Because we did everything that stressed us out and put all this crap in our veins, right? And our arteries. So here's your normal blood flow. Here's your arteries. Clean as a whistle. Now, what is this?
Plaque.
It's plaque. What is plaque? Lipids. Now we see why the high cholesterol is a big factor in this. And guys, I've only seen this once or twice, and this is so gross. I've drawn blood, and y'all ever cook something, and in the morning you put it in the refrigerator because you don't want to mess up? What was on top of it? A fat film. And I'm like, y'all, there was a little white film on the top of it. I was like, I looked at the doctor, I said, what is that? And he was like, bad living. And I'm like, what? He said, Shayla, that's lipids. I was like, we're going to cut you, you're going to bleed gravy. What? Sometimes it is bad genes, but there's nothing you can do about that, but you sure can change your diet. So, what happens to the blood flow? It starts constricting. Then what happens? The plaque is there. Then what happens? The clot does what? It's got to do something before that, probably. It's going to rupture. What does it put in the bloodstream? Stuff that don't belong there. What does the body do with stuff that don't belong there? It attacks it. So it's like, oh my God, I've got all this inflammation. I've got an injury to the system. What am I going to form? Clot. It kind of gets confused. I know it's not blood, but when that plaque ruptures, you've got a tiny injury. Your body's going to form a clot. So we had a little occlusion, plaque ruptured. Heaven forbid if some of it goes floating through the body, starts forming a clot. What's happening to blood flow? It's going to decrease until what? It is completely obstructed. Unstable angina. What does NSTEMI stand for? Non-ST segment elevation myocardial infarction. That's a mouthful. And then STEMI. Partial occlusion. If there's total occlusion, it's not a non-STEMI, and you are going to see that ST segment go up. And we're going to talk about that in just a second. This is a normal PQRST complex, right? Everything looks beautiful. What about here? If you don't know what the J point is, I didn't put it in here. You need to look it up. You can't figure this out without that. The J point here, QRS, is right where that little dip down comes back to the isoelectric line. Where is it here? It's right there. Do you see what I'm telling you? This is the J point. Now, where is it here? It's right there. That lets you know what? It's inverted or depressed. What is this one? It's elevated. If the ST is high, your heart has died. You have got active injury and cell death. Necrosis. If the ST is low, I've got low O2. What's the other name for that? Ischemia. Now, why do you have chest pain with this? Why does your heart hurt? Do what now?
It's trying to pump through the resistance.
It is. It's trying to pump against resistance, so you've got more stress on the heart. Why else does it scream? Lack of oxygen. If anybody has ever put a tourniquet on a patient, they're going to scream. It hurts bad. They beg me, Tammany, please take it off. I can't take it off. I'm going to take it off myself. So you let them take it off, bleed out a little bit, pass out, put it back on. No, don't do that. Your heart is screaming, telling you, I don't have oxygen. They start having chest pain here, and it's pretty bad. How bad do you think it is here? Severe, excruciating. Guys, when you see a test question, and I put kind of, it's different than if I put chest pain, excruciating, crushing, severe. This is how you figure out test questions, because you're going to be like, oh, these are the same. No, they're not. I said chest pain, severe, crushing, started with exercise. What might that be? It's either an NSTEMI or a STEMI. Even if the patient is not having a heart attack, is that the only thing that causes that inverted ST segment? It is not. Lack of oxygen. What if they're bleeding out? You'll see it flip. And then you'll start seeing them have PVCs. And then a lot of them. What's happening? PVCs are indicative of what? You fitna be in a world of hurt. One PVC every other beat. Bigeminy. One PVC every third beat. Trigeminy. 5 PVCs together, a run of VTAC. Now we're in VTAC. PVCs are indicative of ventricular what? Irritability. What makes them irritable? Lack of oxygen. If your patient is bleeding bad, and you go in there and y'all have got the IVs going and y'all are talking about things, and you start seeing all these PVCs, do you need to do something? You do. Whatever you're doing is not working. What could you do immediately? In a perfect world, what'd you say? Give them oxygen. Am I talking about nasal cannula at 2 liters? Hell no. What? And I want that little ball is going to be quivering at the top of it. If you got 25 liters, then put it on 25 liters. And you might be, well, they're bleeding out. Yes, I know. They got 1 hemoglobin floating around, but I want to put as much oxygen on that. I'm going to drown it. You need to maximize the oxygen on the blood cells you have left. This is just a picture for those of us that like pictures. So, for unstable angina, you might see this. It's got a partial occlusion, right? What about cardiac biomarkers on this? Positive, not positive? Not. You will not see any changes in troponin here. Guys, this is a progression, right? If we don't change nothing, if we don't do nothing. There is minimal occlusion here. When does this start? Patient's going to come in and tell you what? I was out mowing the yard and my chest started hurting. So you're going to tell them what? Sit down. We're going to give you what? Nitroglycerin, unless you take what? Viagra. What's the other word? phosphodiesterase inhibitor. Guess what the NCLEX gives you? The generic. And if y'all don't hear me say the generic, because I'm still, then you need to correct me. That's what we need to say from now. Yes, Viagra, Cialis, any of those. You know, I tell you the honest truth. Why do I want to know? How does that have its effect? Vasodilase. All right, I got all my blood down here. What does nitroglycerin do? Vasodilase up here. Yeah. Your blood pressure is 40 over dead. And guys, it takes a minute. Nobody can embarrass me to get it back up. Oh my. Anyway, is it just men nowadays? It is not. I don't know if it has a profound effect. I don't really know how well it works. I haven't ever talked to anybody that's taken it. Are they going to tell you immediately they're on this? No. Unless they've already been prescribed nitroglycerin and they have warned them, don't do that. Why? Why am I giving them a vasodilator? Right, I've got constricted blood flow, right? It's like when you're having anaphylaxis, what do your bronchi look like? Tiny. I give them something and I want what? I want to expand that back out so I can get my airflow through there. Nitroglycerin affects the coronary vasculature even more than anything else. If I've got a blockage, open that vessel up. Is it permanent? It is not. Why do I not want my patient in pain? Cause tachycardia. Tachycardia increases what? What else? If you pump, what'd you say? You said it. Who said it? Oxygen consumption. Why is your heart screaming? My oxygen level is low. I don't have any. I'm dying. Hey, let's jack the heart rate up. You're going to increase that site of what? Infarction. Pain relief. You think they're scared? Terrified. Especially if they've had a heart attack before.
So if they're on Viagra, what can you give them?
I don't know. But we're going to look it up. What she asked, if they're on Viagra, what do we give them? I don't know. Not nitroglycerin. But we will look it up. So, has anybody, and y'all be honest or just don't raise your hand, has anybody watched the pharmacology review? CREMS? What's the class? Nitrate or what? Vasodilator. Why are you giving it? Reason. Chest pain, I want to vasodilate. Mechanism of action. Vasodilation. Assess before. Blood pressure, heart rate. If it's 80 over 40, are you giving this nitroglycerin? You better not. Monitor after. I don't know if it worked. Your blood pressure came down and the chest pain stopped or got significantly better. How about the troponin here?
Elevated.
It's going to be elevated. You have actual cell death. You just don't have a total occlusion. The chest pain here is worse than here. But how may they tell you this started? They were doing what? They were still at rest, or they're usually doing a strenuous exercise. It might come on a lot faster, and it's more severe, and it might take longer to get rid of. Unstable angina, no positive troponin. You don't really have any EKG changes unless you've got a little dip in that ST segment that's showing your oxygen is low. The non-STEMI, and the next slide is the chart. Your troponin is elevated. You've got active what? Cell death. What's the highest troponin anybody in here has ever seen?
Like 18,000.
18,000? There's a guy, 26 you said? Somebody said 26? Going once, going, no, just kidding. There's a guy at Tenova that came in and he really did not fit the picture. His was 32. Here, complete occlusion. What does this mean? Transmural. Trans means across somewhere, right? Where is this injury? It is across the entire muscle. It goes all the way through. This is where the infarction is spreading. And it will spread until that left ventricle is dead. And you're in cardiac arrest. If you have that happen and you go into cardiac arrest, what do you think your chances of getting it back is? Not a snowflake, snowballs of two little snowflakes in Whoville of getting them back. Their heart is dead. There is no getting that back if it has completely gone all the way through the muscle. Here's a J point. There's your ST segment elevation. Here is just to kind of put it in a chart so you can see normal biomarkers, partial obstruction. I don't have active cell death yet, but it's starting. Now, you see urgency. Urgent, but not critical. Non-STEMI. So this one is hard. Your patient's going to come in, chest pain. They don't have, when you see ST segment elevation, we know, right? That's what this is. This is not. And there are things that can cause that ST segment depression. You can even have some things that will put a little bit of, if a patient is in septic shock, bad, they will have a little bump in their troponin. Why is that? They are sick, but it's not going to be like this, and it's sure as hell not going to be like this. The only time you get these levels are when the heart is directly involved. Urgent, higher risk. This one depends a lot on what? Not all this. What comes before all that? I ain't talking about any machine. And how do I figure out their symptoms? Your assessment. That's what the doctor builds this on. We run the EKG. I've got chest pain. It started at rest. We're going to run all the labs. There's no, and if they think it might be, but not really, and the patient's not showing a whole lot of signs and symptoms, what test might they do on them? A stress test. The only time they do that is if they are 100% completely stable. And it might be that first one. They're not showing any EKG changes. They're not showing any biomarker changes. But do I just want to let you go home? No, I don't. They will keep them for 24 hours and either do a chemical stress test, or you got to get on the, hey guys, I never knew what was involved in this. You got to get on the treadmill and they jack it up to a 9% incline. You've got to hold on so it doesn't yeet you off the back of it. Why do I have that up there? Because I don't want you to memorize all this. I don't. But I put that up there for a reason. If I look at ST segment elevation and I just go, yep, that's a STEMI. It has diagnostic what? Criteria. These things have to be in place or it's just a little bit elevated. new. ST segment elevation at the J point. We already talked about that. And two contiguous leads. What's that mean? They are next to each other. It could work out like this. That they not. This one be next. No. These are contiguous leads. This, and this is contiguous leads. And that. What do those represent? Parts of the heart. I'm not picking on the young ladies or the young men, but it's really hard for me to show this on the lady. Can you step up here? Why are we doing EKG? Why the lead placement is important? So where do we put the first two? S1, S2. Right here, right? S1, S2. I'm going to come down and I'm going to put 3, 4, I'm going to put 6, and I'm going to put 5 right there, right? 1, 2, 3, 4, 5, 6. One on where? Each arm, and one on what? Each leg. What does that do? This is a camera, and it's setting right here, and it takes a picture, and it goes through every plane of the heart. Hey, what don't kill you makes you stronger. Just kidding. I don't know nobody in Freedom. It's taking a picture from every different angle of the heart. So, if I've got S1 and S2 right here, what is right there? What's underneath it? Your heart is right in here. If my heart lays right in here, and here's S1, S2, the septum for the heart is underneath that, right? This, wait a minute. Hey, don't you? So, V1 and V2 are a septal heart attack, right? Y'all don't have to write this down. I'm trying to show you why we do an EKG. Now, you're going to need to figure out ST segment. So, what about lateral? Where did I say V5 and 6 are? Right here and right here. Medial or lateral? Lateral. It's a lateral MI. Do you see what I'm showing you? Guys, on y'all's first clinical, if you don't know how to put on an EKG, you need to get somebody to show you how to put it on right. I walk in, and do y'all know what I mean when I say a woman has pendulous breasts? That means they hang down a little bit here. We're going due south. The EKGs were on their boob. How good is that? It's not at all. You might as well put it on the floor. So, now this is important. Right here. 2, 3, and AVF is an inferior MI. All of these are important. What do these mean? If I say you've got an inferior MI, can I actually figure out where the clot is? Yes, you can. This area comes to arteries of the heart. That's why we do that. Sometimes it's a whole hell of a lot more important than, it's always important. There's 2 cases where it's really important. Y'all heard of the Widowmaker? Left anterior descending. Guess what muscle in like 99.9% of the population it supplies? The left. Without your left ventricle, you're going to beat anything. Nope. You kill that, you're dead. If you see ST segment elevation here, you can bet that's the one it's affecting. If you see it here, right circumflex, left circumflex. I want to look at this one. Y'all don't write this down. I'm trying to get you to understand something. Now, about the in-STEMI, yes. All right, I've got a clot. And I see it in these inferior leads. What did I say? Right circumflex, right? The other one affects the left ventricle. So we're going to take out the entire pump in the LAD. So that's the widowmaker. If you got a big occlusion there, a lot of times they don't make it out of the cath lab. So, right circumflex. Does anybody have any idea what that supplies in the vast majority? The right atrium. What's important about that? Huh? It is. So, it is. I'm going on blood flow right now. So where does the blood dump? Somebody walk me through the blood flow of the heart. From the body. Superior inferior. Where's it go? Right atrium. Where's it go? Then where? Lungs. Comes back. Pulmonary vein. That's the only vein, Eclipse loves this. Only vein in the body that carries what? Oxygenated blood. Dumps in where? Left atrium goes through. Left ventricle comes out to the rest of the body. So, the amount of blood that is dropping in here is the entire amount that the left ventricle is preloaded with. Why do I care about preload? Y'all have to figure out these terms. Preload, cardiac output, and systemic vascular resistance. We're going to go a lot more into that in shock, but I want to focus on preload. This is the entire amount I'm pre-gaming with that is going to give to my left ventricle to pump out to the rest of the body. If my right atrium is dying, how much blood's going to get through? You might cut it in half. That cuts your cardiac output in half. That makes your blood pressure go to crap. So, if I see active ST segment elevation here, here, and here, 2, 3, and AVF, this is an inferior myocardial infarction. This is why I'm telling you this is important. What is nitroglycerin? Is anybody worried right now with that inferior infarct? What's your preload? Bad. Now I'm just vasodilate and change the size of the container. Now your blood pressure is what? Nothing. This is just Professor Horton's rule. And everybody that's ever worked on the ambulance, I know that our coworkers just mean the best, and they do. If this is your patient, and you go into lunch, you start that IV before they come in and give them the freaking nitroglycerin. It took me 2 hours to get her blood pressure up, and I was scared. She didn't look at the EKG beforehand. If you guys don't figure out any, and this is important for your test, if you don't figure out any other ST segment elevation pattern, figure out that one. Now, does that mean the physician's absolutely not going to order it? It does not. But what might I do that can help me? Huh? Fluid bolus. Fill the tank before you cause vasodilation, or before, you're going to give them nitro. I need to give them some more volume to fill the tank, because I'm just going to change what? The size of the container. So if this is my container, and I'm just going to give you something that vasodilates, and you keep the same volume, what happens to your pressure? It drops. If this is a container, and I know I'm going to do this, and I fill it all the way up, and it comes, the drop is what? Less. Y'all just figured out hemodynamics right there. Yes, ma'am.
So what you're saying is before we give nitroglycerins, you want to make sure there's not an ST elevation in the inferior?
If there is, you better have an IV in place, and don't let any well-meaning nurse give them nitroglycerin until that physician comes in there and orders that fluid bolus. What if your potato? God! What if your potato has a history of congestive heart failure? Bad. You might give it. You're not going to give what? As much. If they sold you 500 on everybody else, it might be 250. And what are you going to monitor continuously?
Lung sounds?
Who said it? Lung sounds. Why? If I've got congestive heart failure and it's left-sided, we just did the blood flow, where does it back up? Into the lungs. If I have left-sided heart failure and I am flooding their system with fluid, how are you going to tell? This is you. This is not the physician, the PA, the nurse practitioner, God. How are you going to know? And guys, you've heard of flash pulmonary edema. This is when that happens. And when you intubate them, it flows out the tube. That's bad. If you don't monitor your patient and catch that quickly, they're going to die. On unstable patients, you're in there every 5 minutes. Or you ain't even gonna leave. You'll be right there. Yes, ma'am.
Okay, so we need to understand this concept, but we don't have to know specifically these areas on
The inferior you do.
Okay.
It's gonna be on your test.
Okay.
Why is that one? Why am I testing you on that one? If it's the LAD, they're gonna be dead. That's the one that's important for us to know the right assessment to do. Even if you weren't sure if it's an inferior, what might you say? Just double check. Guys, there's nothing wrong with that. And if you say, oh, that's ST segment elevation and it's not, okay. Guys, I've called it before and they're like, no, that's not. There are things that can kind of mimic it. That's up to the physician in the emergency room, the ICU, or the cardiologist to figure out. What is our job as a nurse? Look at that EKG and say, what? That ain't right. You don't have to know the specific area, but you need to go get someone that can start this. Who are they going to call immediately? Who are you going to call? Immediately. Cath lab. They might not be there. They might have 30 minutes that they can get there. Or they might have somebody on every table and your patient's having an active MI and is now flipped into a 3rd-degree heart block at a rate of 30. Yeah, I was nervous. They might need to move somebody off the table that's not as critical. If they're not there, what's the gold standard for all this? For diagnosis of a myocardial infarction and treatment. They got to go where? The cath lab. That's where they run it up through. They send it down. They're like, oh, Lord, I've got a video of that. Without that, we don't really know where the injury is. And I've had patients go down to the cath lab. We would have sworn, like, we down there having bets that they're having an MI. Where is that? And they come back and it's not an active myocardial infarction. They might say, we worried about all this stuff. They didn't see any blockages. They have to get to the cath lab for that. You can be as suspicious as you want. They've got to go to the cath lab for that diagnosis. Now, these are just some examples. Where's the ST segment elevation here? 4, 2, and V3. And where? V1. Where is this? Heart attack. Y'all can guess. V1 and V2, what we say? Septal. Now, is this the front of the heart or the back? It's the anterior, right? This is the posterior. This is lateral. So, 1, 2, 3, 4. What did I say was lateral? 5, 6. I promise I have a reason. If it's 3, 4, is this the front of the heart? It's an anterior MI. You don't have to know that, but I'm showing you where the injury is. Is this elevated? It is not. This one. V4. Where else? Is this one elevated? Guys, I really would have to print that out, but it sure looks like it. Yep, that's all that took. What do they call that? Tombstones. Or you might, it depends on where the person works, is telling you this. You know how a firefighter's hat looks? Either way. This is active heart death. We already said this. Unstable angina, chest pain, at rest. We're going to let them take a break, take the stress off, rest, nitroglycerin. What assessments are we going to do? When does my assessment start? As soon as I walk through the door. You need to be looking at your patient. I don't care if it's a child, adult, kind of in between, doesn't matter. Because you can look at somebody and be like, they sick. Right? Are they yelling for a turkey sandwich and a blanket? Is that person probably sick? No. What else are we going to assess? Vital signs. What does that incorporate? Blood pressure, pulse, respiratory. I want to listen to lung sounds. If they have pulmonary edema, what sounds will I hear? Crackles. That is what in the lungs? Fluid. You said pulses. Where am I going to check them? Pedal pulses, which are where? In your feet. Where else? Radial. One side? Both sides. And if you chart is your patient has +5 pedal pulses and they have on combat boots that are laced up, what did you just do? Like a cheap rug. It was one of the paramedics that worked. I was a manager of the service. We were at the hospital. I wasn't going to embarrass him, and the patient wasn't that bad. But he charted it. Everybody else left the room. I took him back in there and pulled the curtain. I said, you said PMS times 4? Yeah. I said, how's he still got his boots on? Guys, if you chart it, you did it, right? What is that? Lying. Falsification of documents. Don't do that. Skin. What do I check on skin? Color, temp, condition. What's condition? Sweaty. And see, I ain't even gonna tell y'all, but have you ever had those words that you can't stand when somebody says it? Guess what mine is? Moist. Oh my God, I can't. Oh my God. And if anybody who's in my clinical group, y'all better not do it, because they walked by the last day of clinicals and they put moist in everything they could. Boy, it sure is moist out today. I was like, I hate y'all right now. The occlusion here, is it partial? Yeah, and it's not quite as big. It's definitely not as big as a complete. Lack of oxygen, myocardial infarction. This is the NSTEMI and the STEMI. What does the NSTEMI look like? Chest pain. Is this one worse? Yes. They're going to tell you it's worse. Guys, a lot of times they'll tell you they're out mowing the grass, working in the garden. What's another thing they're going to tell you they're doing? Huh? Having sex. I've worked 2 codes right now that it was right there in the guys. If you're doing this right, it's a little exertional. I guess it was in there. Because usually if they've had chest pain in the past, unless they're trying to get more healthy, they're not the marathon runners. So anytime they have any sort of exertional stress, they start having chest pain. Why is that? What is it doing to the blood flow? It's increasing. Your heart rate goes up, right? It's just going through there faster. With an in-STEMI and a STEMI, what is the objective? I need what? I need to reestablish perfusion as good as I can get it. Where's the only place you can do that? In the cath lab. That is the end goal. I need to get that oxygen don't go where the blood don't flow. I need to get that blood flow going back through there. Now, what else do I have to put along with that? Antiplatelets and anticoagulants. Is that the same thing? No. It is not. What antiplatelet do we give every? Aspirin. Aspirin is not a blood thinner. What does it do? It makes your platelets. I need a nap. Your platelets slippery. Plavix is the same thing. Those are your antiplatelet medications. How do we give it to them? You give it oral, and you're going to tell them what? You got to chew it up. Most places that are nice have baby aspirin. They're 81 milligrams. How many do I have to give? 4. This is in the MI. This is not prophylactic. 5 years down the road, I got atrial fib, and this is going to keep up. Y'all don't need to know the dosage, but I'm going to tell you, if you give this in the MI, they're going to tell you to give 4. Now, if they're not nice, they're going to give you that gross 1/325 that you got to chew up, and it's terrible. What anticoagulants? We're going to do heparin. I'm not talking about when they get out. I'm talking about now. What test? Cardiac biomarkers, EKG, CMP, chest X. I did not put it up there. Your coag study. Somebody said it. PT, PTT, INR. Why do I want this? What am I looking at specifically? Who said it? Which electrolyte? Potassium. I'll throw right along with that magnesium and calcium. I never knew that calcium had such a big part to play. What kind of medication do we give to rapid heart rates? Calcium, channel block. Yes, beta blockers. You're right. Calcium channel blockers. So if there's an issue with your calcium and you're blocking them, they always have a CMP done. Potassium, sodium, calcium, and they'll throw magnesium in there. Why am I doing a chest x-ray? Do they have pneumonia and that's why their chest is hurting? And we need to go down the sepsis route, right? Which one's first? Always. Then what? I need it. And I need my coags in case I'm going to give heparin. We're going to take them to chest x-ray. This is not always. This is a maybe. This is after they're stabilized. You can't take them down to the echo lab if they're dying. But this gives you what? It gives you an ejection fraction, which means what to us? How good the cardiac is beating, how healthy it is. If your ejection fraction is 5, you low sick. If you work in an emergency room or ICU or hospital-wide, basically, which one of these do we draw, or do we draw all 3 nowadays? Most places don't draw all 3 anymore. Do you know why? This one is what? Cardiac specific. If you do get a bump in it, a little bump, That is not a heart attack. What about this one? What does it include in there? And this one, they don't even run it anymore. It is not worth a damn. Now, I guess I shouldn't say that. If this one is hellaciously elevated and so is that one, then it's an MI. But why are you going to run both? Most places now just run a troponin. Now, you need to be aware, different facilities have different what? Ranges. When does it peak? Usually 2 to 4 hours. That's important. It can take up to 12. That is not the norm. 2 to 4 hours. It can stay up there for 18 to 24, and it can stay elevated for up to 2 weeks. I'm not asking you about either one of these. Troponin is very important.
I think that takes 2 hours.
2 to 4.
So we're striking out the 18 to 24.
Scraping up to 3 to 12.
It takes 2 to 4 to rise. Yes, ma'am.
So for like the troponin levels, you said you saw like 32,000. So like what's a number that would be alarming?
You would have to see the range for your facility. Like I said, different places. Like let's say that this is not real. Let's say it says 0 to 20 and it's 100. Anything over 20 is alarming. Now, his because they have high, critical high. The lab's calling you because it's, oh my God, high. They're going to call you on critical high. Like, I didn't even get it back in my hand and the lab's calling. Because it is more than alarming. It's alarming if it's 100, if that's your range. Now, what if it's 18? Do I just say, No. You need to be careful. It's doing what? It's right on that line. It might not go up. This is a patient that's probably going to buy themselves a what? A 24-hour stay. We're going to run them again. They came in with chest pain. They came in short of breath maybe. Oh, I sat down and I stopped having chest pain. And it's right there on the line. We're going to keep you for a while. 2 to 4 hours is usually the time you see it to go up. You guys need to stand up and stretch. Take a minute.
Elena, you guys want to open the poster and see what it looks like?
Yeah, I'm scared. We're opening the poster to see what it looks like. Please. What'd you work out today? Who did that? With what? I like
Sorry, girl. I just don't like when it starts to get slow, like 55.
Hey guys, I am not giving you any questions about stable engine. Don't. I'm not saying it's not worthwhile looking at, but you got to know where you came from to get where you went. Fair? Fair.
Hey,
RCA radio, TVs, whatever. Way back in the day, right? So, is it fair to say there versus like even Vizio, LG, they are an inferior product? RCA is an inferior MI. 2, 3, and AVF. RCA is an inferior product. I said that one time, everybody's like, I was like, y'all don't know what RCA products are, do they even make them anymore? It's she's like, I'm so confused right now. You're just too old.
We're going back.
So no, it's like Sony, it's like they made radios, TVs, and stuff like that. But that was years ago, like some of the ones that we had was black and white. So, right, shut up. They don't really make that anymore because there's so many better products. There's LG, there's Vizio, there's, what are some of the other ones? Samsung. Even for radio, I mean, we had RCA radios. They don't make them anymore because they're inferior electronic products. And inferior in mine is RCA, right circumflex artery. That's why I said that. And this is why I stopped saying it, because they're going, but that's why. I have to look up RCA. It had the little rabbit ears on it. Your mama probably got one up in the attic. Somebody comes in and tells you they have absolute crushing, severe, crippling chest pain, short of breath, nausea, vomiting, fatigue, or what? Heartburn. Might it not be heartburn? Sometimes it's hard to tell. You're going to do your assessment. It's the same one. Breath sound, skin, vital signs, generalized assessment, sick, not sick. When does this chest pain start? This is what statement is going to make you nervous. It woke me up out of a dead sleep. You wasn't doing nothing but snoring, and that's not exertional, usually. It happens at rest. When you do a pain assessment on these patients, what questions do you ask them? O, P, Q, R, S, T. What's the O? Onset. Why is that important? If we have a huge clot, what medicine might they get? TBA. What if it started 12 hours ago? You ain't getting it. Time of onset is just like a stroke. I have to know what. When did this start? If you with Memo and she got an altered level of consciousness, when did she start saying my chest is hurting and grabbing her chest, short of breath, diaphoresis? Even then, if it's questionable, are they going to give TBA? No. They're going to have to walk. That's going to be the cardiologist to decide. Might they give it? They might. They're going to do the risk and benefit. If there's any doubt that it's over that time limit, they're not giving thrombolytics. It kills people. What's the P? What provokes it? Or what is palliative? I probably spelled it wrong. What makes it worse? What makes it better? What might they say makes it worse? Running, exercise. What makes it better? When I sit down. Q. What does it feel like? What responses make us nervous? Like that damn elephant sitting on our chest. I don't know where that elephant comes from, but he needs to go home. Or how might they describe it? A pressure, a crushing pain, a band around their chest. Now, what's the R? Does it go anywhere? Where might, a lot of times they say, left arm, guys, it can be the right arm. Don't just say you can only have symptoms in your left arm. Jaw, mid-sternal, it ain't radiating then. S, severity. How are you going to tell you, ask your patient? On a scale of 1 to 10, 10 being, guys, sometimes do we have to break this down? We live in the South. I'm simple. They're simple. And guys, am I talking about this person's intellectual level? If you walk and say, ma'am, you're having a myocardial infarction, are you shortness of breath, shortness of air, are you having emesis? They're going to be like, do what? The doctor's going to walk out and there's going to be, you know, if you're talking to them and they're like, no, back up. And it's not saying they're ignorant. They might be simple country folk. Does it feel like a bear is chewing your arm? Yeah. It's that bad. Or does it feel like a wasp just stung you? Give them something to figure this out. How scared are they? They ain't going to go to this. 0 to 10. 10 is the absolute worst bad pain that you've ever been in, and a 0 is none. Ready, set, go. Huh? What about nonverbal cues? Oh, it hurts so bad. Now, do you know what reproducible is? So, if she says, oh my God, my arm hurts. Doctor, it hurts when I do this. Don't do that. If it hurts right here. And she says, oh, my arm hurts, my chest hurts. And I push right there and she said, oh, that hurt. Don't do that. Is that probably a heart attack? It is not. It is point tender. That's bone, that's joint, that's muscular pain. They can't say it's hurting right here in this one spot. It's not going anywhere else. That's not a heart attack. A heart attack is you can't pinpoint it, and it might go other places. It hurts when I breathe in and out. That's linked to what? That's your respiratory system. That's the pleurisy. That's something else besides your heart, right? Breathing in and out and it hurts, is that necessarily always shortness of breath? It's not. Now, might it be linked? Because pain makes you do what? Fatigue. Ladies, we just don't act right. We just don't. And especially if they're female and diabetic. What problem do diabetics have to deal with? Peripheral neuropathy. The nerves don't work right. They don't get the right pain sensations, right? If you have, even my age, 50 and up, comes in and says, God, I'm so tired. I just don't feel right. You better run and get the EKG. They got diabetes. Now, my young men, even if they get, in my age and up, this is I got a chest pain, I got this, I got that. A lot of times when the women are having an MI and they say, I just don't feel right, I'm short of breath, a lot of times it will be accompanied by which one of these do y'all know? Nausea. Do they usually throw up? No, they just said, oh my God, I'm so sick on my stomach. And then they're sweating real bad, right? Diaphoretic. Why are they doing that? What's causing that? Huh? Kind of. Pain causes what? Tachycardia. What nervous system does it enact? The sympathetic nervous system. Your body's in fight or flight. I don't care. Your heart is dying. So I'm in fight or flight. My heart rate goes up, and I dump all that epinephrine in there, and what happens to my sweat? It starts flooding out. Have y'all ever been really scared and now you think you're going to throw up? That's that epinephrine that gets dumped into your system, and that's also what creates that impending doom. I'm fixing to die. Well, your body wouldn't be in fight or flight if you weren't dying. Is that fair? here again, what is the objective? We need reperfusion. Cath lab. Guys, there's something else we haven't talked about on here yet, and I should have included in the beginning. I said we have to treat pain, right? What other meds besides aspirin? Morphine, maybe. Not so much anymore, but it's still there. Morphine, oxygen, nitro, and aspirin. We always said Mona greets everybody at the door, right? They're about this close. We took it off life flights, aircrafts 10 years ago. We never gave it. They've almost proved, like within this much, that we don't need to give it in a heart attack because it can get in the way of the thrombolytics. I need to reperfuse. That will stop the pain. I don't need something to block my TPA. But it's still there. You will not get a question on it, I promise, because some places don't give it. Does that mean that you won't see it given? You will. But it should not be first. Which one should be first? Oxygen, and then what? Nitro. Now, there's 2 or 3 things that you have to do when you give a nitro. What are they? I'm talking about you. You need to have gloves on, or you're going to hit the floor. This is F around and find out. Y'all don't play with the new nurse. Say, here, hold these. I've seen it happen. Or heaven forbid that liquid that you put on that. Oh, Lord, I got some on my hand. We don't really use the spray anymore because of that. I'm going to spray. What are your eyes? That is instant mucous membranes. You will pass the F out. Guys, priorities, right? Safety is in there. Is it just the patient's safety? No. NCLEX loves pharmacological safety questions. If you're going to give nitro, you need to check what? If you're going to give nitro, you need to have your gloves on. Guys, that's safety. If you're going to give something down the ET tube, don't be standing over it so it blows back in your face and it's atropine and now you're vasodilated and you don't realize that and everybody sends you over to the CT because they think you're having a stroke. It was only one pupil. We were like, oh my God. And then she was like, we had coded a patient. We don't usually give it down the ET tube, but they didn't get the bag back on it fast enough and some of it sprayed back up and a drop got in her eyes. And it caused dilation of her pupils. We didn't figure out until after the CT and the code stroke and yeah. All right. Turn off. Y'all go to sleep. Do something. It's fast, right there. Guys, that ain't there. That's, look. It's like a ghost vessel. Ain't nothing in there. 100% blockage of the RCA. This person is having what kind of heart attack? An inferior. Right there. What is that you're seeing going through their vessels? It's a dye. They only do that where? Alright. What is this? That's the reduced blood flow, and that's what? Plaque. What am I showing you? What are we going to do? They're going in an artery, in the radial or the femoral artery, and they're going to do what? They're going to put that guide wire up there. What am I going to put in the cath lab? A stent. This is going to show you. So they put the dilator, they put the guide wire, and then they start what? They're running the guide wire up. And where is it going to go? It comes down the aorta and goes there. They will start injecting the dye and they will figure out where it is. So, you see it? What is on the end of that? It's a balloon, and what's on the balloon that's collapsed? That's the stent. This is showing you the dye, that's showing you the blockage. There's the wire. We figured out where it is. There's the balloon. And they're going to inflate it. What just happened? What might happen? You're gonna dislodge some of that what? That plaque. Risk versus benefit though, right? That's a stent. So they'll put it on that little balloon. They'll inflate it, and then what happens? Deflate the balloon, take everything out, and that stays. How long are they going to be on Coumadin, warfarin, whatever? Lifelong, and probably aspirin. If I don't do what I'm supposed to, can this reocclude? Yes. Absolutely, it can. So we said the meds that you give during the event, right? After the stent is placed, we even said aspirin, Plavix, heparin. Post-reperfusion care sometimes involves what meds? Beta blockers. What if I said I need a medicine to make my heart beat better? Huh? Who said it? Digoxin. Digoxin doesn't help you with the rate. It doesn't slow it down. It makes your heart beat more effectively. What is chronotrope? It's speed. So inotrope is what? Contraction force. So if digoxin is a positive inotrope, and guys, these terms are important. Not so much dromotrope. I don't even actually remember what that is. Guys, you'll find out I don't commit it to memory if I don't feel like that I need to absolutely know it. Digoxin, positive inotrope. Beta blocker, positive what? Chronotrope. It slows it down, the speed. What else? What other? Somebody said it earlier. It's not so important like during the event, but this medication is very important after. Statins, because I might have disrupted some of the plaque, right? And what kind of diet they need to go on? A healthy one. Grass from here on out. You can have some grass, that's it. What is this? Most places you can only put, I think it's at the maximum 2 or 3 stents. After that, they have to open your chest. What are some complications do you think of angioplasty? Even cardiac catheterization? Huh? Hellacious infection. You're going in an artery, right? And you're going down in their heart. If somebody's not washing their hands, if somebody scratched their booty, whatever, infection in an artery that went right main line into your heart. What else? Hemorrhage. Guys, they can rupture when they're doing that cardiac cath, any of the vessels. They can put the wire through the septum. None of that, yeah. Yeah. What else? Stroke.
Dislodge or clot.
You just dislodge your clot. So you got a patient, went to cardiac cath lab, laughing and joking with you before, laughing and joking when they get back. You come back in, they got an altered level of consciousness. You scared? Sure are. But Ms. Horton, we gave him heparin. I don't care. We just started the heparin. We're trying to treat the fallout. Well, the fallout has happened. Patient comes back from the cath lab. This is important. Prioritization. It's not just in the emergency room. This patient's coming up to the cardiac floor. It might be the cardiac rehab. Patient A, blood pressure's 170 over 105. Needs his blood pressure medicine. Patient B just came up, was having an asthma attack down there. It's been controlled, not really wheezing anymore. Respiratory rate's normal. O2 sat's normal. You got a patient that just came back from the cath lab. Talking to you before, you walk in, very obtunded, altered level of consciousness. Which one's first? Guys, even if I had made that half, now, if you walk in and they ain't breathing, they got to take priority. A, B, C, D. If they have an altered level of consciousness, that makes the D go before the, and we need to do what? They can't control their airway. You need to get ready for what? Immediate intubation. Did I say you're doing the intubation? No.
Well, we need to make sure everything's ready for that.
Yeah. And if all your stuff ain't in the room, you're going to have a mad somebody when they come in there to intubate the patient. Guys, this is what critical thinking gives you. Your assessment, you said, oh, he is not right. He ain't laughing. He ain't joking. Altered level of consciousness, his GCS is 6. Immediately, you're going to call everybody. Everybody in the club needs to come in the room. Somebody needs to get out what? The airway box. That physician needs to be coming in there. If you're on the med-surg floor, what you fitting to do? Call a where's this patient going to have to go? They got to go to the ICU. You ain't getting them to the ICU without calling a rapid response. Right? Where do we call a code blue? Everywhere else. If you're down in the ER, you're just going to work your own cardiac arrest. ICU step down, most places, med-surg floor, they call a code blue and people have to come up from the emergency room. Sometimes the physicians aren't there. Sometimes the ICU doctors work their own. If you're anywhere else and it's not a cardiac arrest, if your patient is in trouble, you have to do what? You got to call a rapid response. Let them come up and decide, yeah, we need to go here. No, we don't need to. Hey, we got to go back to the cath lab. What about the site? They put the sandbags, or they used to. Lord, that shows how old I am. Now they got this big clamp that they put on there, and it stays for a while. They have to sit still. They have to lay flat. Because if you went in on the artery here and you're doing my softball throw, and the blood goes all the way down the hole. They have to sit still. Well, what if you had the pressure and it's been the time and then you walk back in there and this is saturated? pressure and hit the code button with your toe. Don't walk out when it's squirting up. So, and I ain't talking about a quarter size amount. No, this is an artery they went in. It will be bleeding.
Filled plaque builds up in an artery wall. Only a small amount of blood gets through. We are now looking at the heart and the main blood vessels. Here is a coronary artery, and right here inside that artery is a
There's the
blockage.
blockage.
Because of the blockage, the part of the heart nourished by that artery is pale from lack of blood. The solution: attach another blood vessel to the blocked artery
Where do they get
just
the
beyond
vessels?
the blockage right there.
In the leg, or
The
they can
surgeon
do
takes a
the
spare vein from the leg or an artery from
memory.
underneath the sternum or the arm. One end is attached to the body's main artery, the aorta, and the other end is attached to the blocked artery just beyond the blockage. The graft bypasses the blockage. Now the blood is flowing from the aorta through the bypass graft and into the artery that was blocked. Beyond the blockage, blood is flowing again to all parts of the heart.
Now, does this 100% solve that problem? Once you have heart muscle that dies, you don't get it back. But if you don't do this, what's going to happen? The patient's going to die. So they actually take the saphenous vein or whatever and attach it here, bypass the graft to get blood flow past the stent. Past the occlusion. Coronary artery bypass graft. They come in and take their scalpel and cut and open the patient's chest. Now, what are really we worried about? Infection. That's the number one thing that happens to these people. But what else? Clots. The same things. And if they've got a bandage in place and you walk in and it's soaked, the same thing. I'm worried about them hemorrhaging. This is just differential diagnosis. I wanted to put this up there. It's not always a heart attack. It might be breathing related. It might have cardiac causes. They might have GERD, reflux, and it a lot of times will make you think you're having a heart attack. Or it might be extra thoracic, somewhere outside your box. All right. And I'll also make a Dropbox for this. Don't worry about hurrying. Just try to get it in there by the first test.